In this video, we'll talk about the mental health care system broadly, and then more specifically about how the mental health care system is financed, or the way that money flows in and out of the mental health care system. And then finally, we'll wrap up with a brief discussion about how counselors get paid within the mental health care system. To begin with, let's review a little bit about the progress that the mental health care system has made over the last couple hundred years. And it's really important to remember that, as discouraging as it can be sometimes to think about all of the improvements that are still needed within the mental health care system, overall there have been vast improvements over the last 150 years when care was either the sole responsibility of families to try to, on their own, figure out what to do with family members who had mental illness, or when individuals with serious mental illness were sent into institutions where they were provided with pretty much only custodial care, meaning that they were kept alive and given the most basic shelter, clothing, and food. And that's where they spent the rest of their lives, oftentimes, or long periods of time. One of the things that kept this type of care from changing was that a lot of people didn't know about it. If the issue didn't affect them, then it largely went unignored. And illiteracy was a big part of that, because the ability for people to write and use the press to expose terrible conditions has been an important factor in advocacy work. So up until prior to 1840, about 50% of the white population in the United States was illiterate. So a lot of people who could potentially do something to change the mental health care system at the time, and using the word system very loosely here, just couldn't read, didn't know much about it. In 1773, in colonial America, Williamsburg, Virginia, opened the first public building in North America devoted to caring for the mentally ill. And if you're following along with the download of this PowerPoint, then you can click on the link here. It'll take you to a little bit of a description about that mental hospital in Williamsburg. There is currently a structure in colonial Williamsburg that you can go into that's a replication of that original mental hospital, and you can tour the facilities and learn a little bit more about the type of care that was provided there. In 1825, there were 9 public mental hospitals, so within just about a 50-year time span, we jumped up to having 90 public mental hospitals in the U.S. And by 1865, the end of the Civil War, we had 62 public mental hospitals. In North Carolina, specifically, we had some progress happening right around the middle of the 19th century. In 1848, the advocate Dorothea Dix visited North Carolina and made an appeal to the legislature to fund a mental hospital. Now, Dorothea Dix was a very important advocate for the mentally ill and for their families who were trying to take care of them, and she made it her goal to try to visit all of the states and appeal to the legislators to give funding to be able to create facilities that could house and care for the mentally ill. So in 1848, she came to North Carolina, and you can learn a little bit more about her visit by clicking on the link there. Many of you are probably familiar with the fact that later down the road, we actually did have a mental hospital built in North Carolina that was named for Dorothea Dix. And that is currently no longer in existence, but the land is still there and marked and named in memorial to her and in the hospital that came later. The hospital was eventually built in North Carolina, and in 1856 it admitted its first patient, who was diagnosed with what was at the time called suicidal mania. In 1868, the person who was in charge of that facility was called a superintendent. His role was a superintendent. His name was Eugene Grissom, and he recognized that more sites were needed, and so he pushed for there to be a facility built in western North Carolina and another facility to be built in eastern North Carolina. And he also lectured on the topic of mental illness at what was then called the Normal School at Chapel Hill, which is now the School of Education or the College of Education at UNC Chapel Hill. So that was really important that discussions of mental illness began to take on an academic role as well. Now, if you read about Eugene Grissom here, you can learn that he had a little bit of a colorful past and was accused of having inappropriate relationships and assault on some of the female patients in that state hospital. And he eventually left North Carolina and headed out west, where he remained in the western part of the United States. So moving on to 1880, North Carolina did open a hospital in the East, as Eugene Grissom had pushed for, and it was specifically to treat the African American community in North Carolina with mental illness, and that is what is now Cherry Hospital in 1880. So you can click on that link and hear a little bit more about that. But overall, from about 1848 to 1945, there was a lot of public indifference to the idea of meeting the needs of the mentally ill. People just really didn't want to think about it. There were other things going on that took precedence, and so it wasn't a high priority. There were meager state appropriations, meaning the states did not want to dedicate a lot of their funds towards treating the mentally ill or towards creating infrastructure that would treat the mentally ill. So the facilities tended to be inadequate. The people who worked in the facilities tended to have low salaries. There were not enough of the staff there, and the staff that was there tended to be poorly trained. The hospital that was eventually built in western North Carolina, as Eugene Grissom had pushed for, was the state hospital in Morganton, and you can see this is a postcard advertising that state hospital. In around 1941, 1942, an attorney named Tom P. Jemison, after a one-year stay in the Morganton mental hospital where he was treated for alcoholism, he published some articles in the newspaper that exposed the horrible conditions that were there, terrible conditions in the way that people were treated, the food that they were served, the bedding. And if you click on this link here, you can read a little bit more about the conditions that he described in those actual news. You'll actually see prints of the original newspaper articles if you click on that link. So that's pretty interesting. And that link also takes you to another set of newspaper expose articles written by an anonymous woman who stayed in the women's ward of the mental hospital and shared about how women were treated. Now going from, that's 1940s, now going all the way up to the turn of the century, from the 20th century to the 21st century, we talk about things that are much more current and still in effect right now in 2015. And one of those would be the President's new Freedom Commission on Mental Health, where the charge that came from the report that resulted from that commission was that we needed to look at the fact that we had a lot of fragmented services or gaps in care, particularly for children, adults who have serious mental illness, and the older populations. Those are still major issues today. Even though we're 15 years later, those are still issues that we're wrestling with today. The New Freedom Commission also called for there to be more focus on mental health specifically, suicide prevention, the impact of trauma, and long-term effects of psychotropic medication. We also had a call from that commission to look at mental illness and substance abuse when they happen together, and to develop treatment plans that would address those two things hand in hand. We looked at ways to provide supported employment for the mentally ill, since there were such high rates of unemployment within the mentally ill. Looked at trying to target some more funding towards early screening so that we could have interventions happening much earlier in the stages of mental health or the stages of mental illness. We know that it's much easier and more impactful to intervene early and try to make changes with someone before that mental illness progresses and has more serious repercussions on their lives. We also started to think more about how technology can benefit and impact mental health care. This is something with the the director of the National Institute for Mental Health recently leaving his post this year in 2015 and going to work for Google, this is something that we're continuing to see a lot of promise in using technology to improve care, to improve access to care, to improve early screening, and then also for people to do some self-management of emotional regulation and things by using apps and other technologies. The New Freedom Commission also, there was something that came out of that was a big push for using research-based practices, and you can see a few of those research-based practices listed here on your screen. Now, those were that was some reform that was focused on the United States as a whole, and the federal government has a role in providing funding out to the states, but ultimately mental health care is a state's issue in that the states get to decide how to utilize those funds in a lot of different ways and decide what's the best plan for mental health care within a particular state. Something that affected all states and certainly had an effect on North Carolina was the Olmstead decision from the Supreme Court in 1999. And what that called for was that there had to be the placement of people who have serious mental illness in the least restrictive environment, and that's what LRE stands for. So this decision required that folks would need to be in the least restrictive environment, and otherwise moving them out of institutions and trying to integrate people into the community in the same way that President Kennedy's Community Mental Health Act in 1963 encouraged. This was now a Supreme Court decision furthering that same kind of thinking. But back to what's happening in North Carolina. In 2001, there was a mental health reform bill that instead of having counties hire their own providers to do community mental health, to do publicly funded community mental health, the reform bill said that now counties would have these organizations called LMEs, local management entities, that would be responsible for the oversight of the public mental health system, but that the LMEs would contract with private providers rather than actually hiring the providers themselves. And from 2001 until current day, we continue to be in a lot of flux with how mental health care operates in North Carolina. But over the time, there have been some trends, and that one of those trends has been a decline in the number of people served by state hospitals. So in 2001, there were 17,000 people served in state psychiatric hospitals, including Dorothea Dix Hospital, to now in 2011, there being fewer than 6,000 people. A lot of the critiques that came out of this reform bill revolved around the use of community support, where people were having unlicensed professionals charging for some pretty expensive services and not that really were not best practices. So LMEs later consolidated. There became fewer LMEs, and they were bigger organizations, and they've changed from being LMEs to managed care organizations, so now they're MCOs. This chart here shows the total number of state beds that are available in North Carolina for psychiatric reasons. So this is for people who are involuntarily committed or voluntarily need inpatient psychiatric care, has drastically gone down since 2001, and this being here that there are 850 beds in 2012 total. So that means at any given time there are 850 spots in a psychiatric unit in North Carolina for someone who needs inpatient care. I'm going to pause here and start over again with a part 2 of the video.